Good evening, everyone, and thank you so much for joining us. We're here today in a webinar discussing ocular Adnexal malignancies, and we have three great guests from all over the world. Thank you, everyone, for joining us. Thank you, Dr. Grynberg, Dr. Lee, and Dr. Honavar. Thank you very much. Okay, so we will have three talks, and then in the time we will have left by 10 p.m., this time we'll use for Q&A. Okay, so let's move on to the first talk. The talk will be given by Dr. Shirly Grynberg. Dr. Shirly Grynberg is a senior oncologist. She is the head of the Integrated Practice Unit Melanoma and Skin Cancer, Ella Lemmelbaum Institute for Immuno-Oncology and Melanoma Cancer Center at Sheba, Israel. Dr. Grynberg will talk about immunotherapy for periocular malignancies. Thank you, Dr. Grynberg.
Thank you. So good evening, everyone. So as you mentioned, today we're going to talk about immunotherapy for periocular malignancies. And when we talk about periocular malignancies, the most common one would be the BCC, and after that the SCC. The BCC is around 80 to 90% of the eyelid cancer that we see, and it's slow growing, but it can be locally invasive. It's very, very, very rarely metastasis, almost never. And it has some interesting systemic treatment we can offer to non-surgical candidates, including the HOC inhibitor in the immunotherapy. Squamous cell carcinoma is the second most common, and it can be slow growing, but also very rapid, and it can metastasize to regional lymph node and distance metastasis. Systemic treatment here include the immunotherapy, and this will be my main talk this evening. There are other treatments we can offer as well. Other periocular malignancies I'm not going to talk about are sebaceous carcinoma, melanoma, Merkel cell carcinoma, and there are some. Okay, so I want to start with presentation of a patient of mine. She's a 71-year-old female. She had a lymphoma treated with chemotherapy. After that, she developed chronic sinusitis, AMD on her left eye. On December 21, she was biopsied from her left conjunctiva, and it was conjunctival squamous cell carcinoma in situ. Margins were involved. She was treated with eye drop of 5-FU and remained on follow-up until 2023, where her disease has returned. MRI that she did on August 23 show a thin linear band just next to the cornea, extending above and below the equator. And there is also, it looks like it's involving the lacrimal gland. So we can see here a photo of the patient around this time. She was discussed in our tumor board, and we discussed the option of surgery, which was offered was exenteration. Other options also include radiation and systemic treatment. The next patient is 70-year-old male. He has non-medical background, which means he never go to doctors. So he also went to check his cutaneous tumor on his left temple. This was growing around 6 months until it started to bleed, had an offensive smell, and started to be very painful. Eventually, he went for a checkup, and it was biopsy, and it was cutaneous squamous cell carcinoma. After the biopsy, like we see a lot of time, we saw a rapid growth of the tumor and redness of the conjunctiva. PET scan showed a 4.5 centimeter lesion on the left temple, and MRI showed a space-occupying lesion on the skin of the left face. And of the temple, it's involved the upper eyelid and left temporal capsule. So we can see here photos of the patient. So what can we offer to this patient? What treatment? Surgery? Well, surgery is always an option. I mean, everything is eventually resectable. But of course, especially when we talk about the periocular area, we always need to remember that the eyes are the window to the soul. So surgery in this area is very important. It's important we will try to maintain as much as possible aesthetics and functional of this area. And in those cases that are a bit more challenging to do it with surgery, we can try to look for systemic treatment. And this is where I'm going to talk about immunotherapy. So immunotherapy, it's usually, in most of the cases, we're talking about immune checkpoints inhibitor. And just quick review to those of you who are less familiar, but this treatment has revolutionized treatment in cancer in the last decade, just a bit more than the last decade, and especially in melanoma and skin cancer. So we are talking about the phases where the immune system get active. So we're starting with the priming phase where the dendritic cell present an antigen to a T cell, and then activated T cell, and the activate T cell find this antigen on the cancer cell and attack the cancer cell. So this is how it's supposed to work, but of course in life it's not always work like that. And since we don't want the T cell to be overactive and start to attack every healthy tissue in the body, this process includes activation signals and inhibitory signals. And you can see here in the priming phase, in the effector phase. So since when we see a cancer develop, we want to turn on the lymphocyte. The immune checkpoints inhibitor are actually antibody that were developed to the inhibitory signals that you see here. So either anti-CTLA-4 in the primary phase, or anti-PD-1, or sometimes anti-PD-L1 in the effector phase. And this is most of the treatment that we use when we talk about the periocular malignancy. So why does it work so good? So periocular malignancy are like cutaneous malignancy. They have very high tumor mutation burden. And you can see here that squamous cell carcinoma is the highest one in the tumor genomic atlas. High tumor mutation burden, it means the tumor has a lot of mutation, it means it has a lot of antigen. We also, when we look at our patients, a lot of them would be immunosuppressed, and we see that the risk for develop cutaneous malignancy is related to immunosuppression. So that's also, it's a good point to see the relationship between the immune system and those malignancy. But when we turn on the immune system and we block the off signal, we can see immune adverse event, which includes every kind of itis. So kind of like autoimmune effect caused by the activation of the lymphocyte. It also includes a lot of different itis in the eye area, but it can be anywhere in the body. Also, something that worth to mention when we talk about immunotherapy is the unique response, and this is what we call the pseudo-progression. So this is a photo of cutaneous melanoma for one of the first trial was ever done with immunotherapy. You can see here at baseline a photo of melanoma in the arm and also in the liver. And you can see that after 12 weeks, the melanoma has grown very impressively grow. And when you look at that, the first come in mind that the disease has progressed. But look at that, after 24 to 52 weeks, the disease is completely regressed. And this patient had a complete response. And this effect is caused by infiltration of lymphocyte and macrophage to the tumor. And sometimes when we look at it microscopically or on CT, it looks like it's growing. So it's always important with immunotherapy to do 2 evaluations before deciding on the efficacy of the treatment. Now let's go back to our patient. So our female with a right conjunctiva squamous cell carcinoma, she was discussed as tumor board as we mentioned, and this is how she presented. We decided, because we didn't want to, well, after this discussion, of course, with the patient, we wanted to try to save her eye, and we offered her anti-PD-1 treatment with cemiplimab. After the 3rd treatment, there was a clinical improvement, and after almost 1 year of treatment, there was no viable tumor that's seen. And this patient still continuing on the treatment with no tumor at all. She's just about to finish 2 years of treatment, and then we can discuss about if we want to finish the treatment and continue follow-up only. The next patient, our 70 years old male with locally advanced squamous cell carcinoma on his left temple. He started cemiplimab as well. And after 3 months only, he had a near complete response. You can see here in the picture. And he continued with this treatment for 2 years, and then he stopped because of a complete response. What we actually did is that we did a small surgery of the leftover skin that you see here in the photo. And it was all with no residual tumor. We also did a mapping biopsy that showed there was no residual tumor left. For squamous cell carcinoma, we don't have any specific study that studies periocular squamous cell carcinoma, but we do have on cutaneous either metastatic or non-resectable squamous cell carcinoma. We have 2 drugs we can offer, and they are reimbursed in Israel and of course FDA approved. Both of them are anti-PD-1. They work around the same, cemiplimab and pembrolizumab, around 50% of response to treatment. But in real world, it's even higher. It's up to 80% and around 20% of complete response. This year, it was also published adjuvant cemiplimab for high-risk patients. It showed improving disease-free survival with hazard ratio of 0.32, and it was also FDA approved. Now, what about neoadjuvant? So sometimes we want to start with immunotherapy and then offer our patient surgery. It's also an option. There are some few studies. All of them are quite small study, like this one. It's a non-randomized phase 2, around 80 patients, which show around 50% of pathological complete response and around 70% overall response rate. But the next study that was also published this year asked a very important question. Do we still need to treat those patients who are responding very well with the same intent? I mean, do we still need to perform the surgery? And some of them, we offer them adjuvant radiation as well. So this study was designed to do de-escalation in the treatment. It gave the patient 4 cycles of pembrolizumab. Then they had a PET scan. If in the PET scan they saw a complete response, then the investigator took mapping biopsy of the target site. And if there was no malignancy left, they offer no surgery and no radiation. And if there was no clinical complete response, they offer a surgery. If the patient had pathological complete response and they didn't undergo radiation, all the patients would continue with pembrolizumab. And eventually it showed, it managed to do around 50% of the patient had total de-escalation from the treatment. And melanoma, I only want to mention very quickly that what's basically changing melanoma in the last few years is the neoadjuvant approach. So we have 2 major studies. The NADINA that you see, very specific to periocular malignancy. But what we did saw is that giving the treatment before the surgery is much better than giving the treatment after the surgery, improving the event-free survival and distant metastatic-free survival. And this is actually now becoming the common practice in melanoma with clinical nodes. So we might consider it also in periocular malignancies, periocular melanoma that are locally aggressive or very bulky disease. We actually saw patients like that just in our MDT meeting last week. So it's still not the standard of care for non-stage 3 melanoma, but it's something we can discuss with the right patient to maybe offer them a better chance for cure, but also to preserve function and aesthetic. What they did saw in the study was very interesting, that the result of the patient, during in 2 years was very dependent on the pathological response. So patients who had a complete response, they are almost 100% that their disease will not recurrent and they will stay free of metastatic. BCC going to for and BCC is not immunotherapy, it's the hedgehog inhibitor, quite good, usually also quite rapid, but the adverse event of this treatment is quite difficult, both for our patient and sometimes for us as well, for managing this patient. Immunotherapy was only approved as a second line because of a small study for patient who had progressed of hedgehog inhibitor or did not tolerate the treatment. But this study also showed around 32% of overall response rate. So immunotherapy has a place in BCC, but it's not as good as when we talk about other malignancies like squamous cell carcinoma, melanoma, and other that I didn't mention, like Merkel cell carcinoma. And my take-home message regarding BCC will be that if we can offer surgery, it usually will be my, in those cases, it usually will be my first recommendation. And we can use the hedgehog inhibitors maybe as neoadjuvant approach or as a bridging until the surgery. Per definition, the hedgehog inhibitor, they are not curing the patient, so they still need to undergo surgery. I do have one patient who had a BCC next to the canthus. She had a complete response, and the surgeon team didn't find what they need to resect, so she stayed on follow-up. But those are not most of the cases, so we will only use it as a bridge until surgery and maybe to try to reduce the extent of the surgery. And I know BCC, especially if it's more fat type, it can be very difficult to resect and find the border. But we do a lot of time need to be aggressive with this disease, especially for those for the more elderly patient and those immunosuppressants. And I'm going to show you two patients of mine with periocular BCC that took them a lot of time to ask for some help, and they did not respond not to the hedgehog and not to the immunotherapy. And in the end, we can only offer them palliative care. I'm going to finish with a bit more optimistic photo that I took actually yesterday in the desert after the first rain. Thank you very much.